Welcome and happy April Fool's Day. Thank you so much for joining us live or on the recording for episode 13 of Dr. Jeff Talks About Sex and Intimacy, Understanding and Managing Premature Ejaculation. I am truly humbled and honored that you have taken time out of your busy schedule to join us. Remember, we are on social media. We're out there on Facebook, on YouTube, on X, you name it, we're out there, and those social media sites. And we do need followers on Facebook. When we have 100 followers on Facebook, we can stream live rather than just the recordings being there. And that's going to be a wonderful thing. So if you are a Facebook person, please follow us. We appreciate that. You can go to our website. Our website has previous episodes, wonderful episodes with really great guests that you can view. You can also go to the calendar and see what's coming up each week. We have some amazing guests coming in the next weeks. All the way through July, there are things scheduled in there that you can see. So please go to our website and watch previous videos or see what's coming up next. You can listen to us on Spotify, whatever you like to listen to us on, we're on there with you. iHeart Music, you name it, we're there. And so listen to us in your cars or wherever you are. We appreciate it. Please know that you are completely welcome here in this space. Whatever your sexual orientation, your gender identity, or your relationship style, you are welcome in this space. All are welcome. So the goal of the podcast is really pretty simple. It's just to empower and enlighten you with evidence-based information, scientific information you need to improve your sexual health and to deepen your relationships. Very simple goal, no hidden agendas. That's all we're here to do. Well, let's talk a little bit about premature ejaculation. It is one of the most common, but often misunderstood sexual concerns among men. It is the most common reported sexual concern among younger men. But the thing is, research shows that on average, also men tend to climax 4 times faster than female partners, men who are partnered with women. This difference makes sense when we consider the anatomy. The penis and the clitoris share similar internal structures, but the penis is externally exposed and more easily stimulated, while the clitoris is primarily internal and often requires more time and varied stimulation. But regardless of gender, most people want the ability to control the timing of climax, to stay present in the moment, and ensure pleasure is mutually satisfying. When ejaculation happens too quickly and outside of one's control, it can lead to frustrations, to anxiety and distress for both partners. So tonight, we are going to dive deep into premature ejaculation. And we have the greatest authority around joining us as a guest this evening. And that is Dr. Stanley E. Althof. He is the executive director of the Center for Marital and Sexual Health of South Florida and a professor emeritus at Case Western Reserve University School of Medicine. Dr. Althof has 40 years experience in treating men, women, and couples with sexual and relationship problems. He is absolutely an internationally recognized researcher, clinician, speaker, author, and scientist. He is the author of hundreds of peer-reviewed publications and has contributed numerous chapters to leading textbooks in psychiatry, in urology, and sex therapy. I couldn't be more excited to welcome the authority on premature ejaculation, Dr. Althof. Welcome to the show.
Thank you, Jeff. It's really good to be here. I hope everybody is doing well this evening and we can add something to their lives.
Oh, I know you will. So without further ado, let's go right into your presentation, and thank you for sharing your expertise.
You bet. Well, hello, everyone. Good evening. So, I'm going to talk with you about the assessment and treatment of premature ejaculation. And you can see that I'm the executive director, as Jeff said, of the Center for Marital and Sexual Health of South Florida and a professor emeritus at Case Western School of Medicine. So if you take a look at this next slide, there's actually sort of a connecting bar missing. But these are the different kinds of ejaculatory disorders. And you can see at the top where it says anejaculation, that's men that don't ejaculate at all and don't experience a sense of ejaculation. Then we have here in green, delayed ejaculation, where it takes men an awfully long time if they ever are able to ejaculate. Many are not able to. Normal ejaculation, and where we're going to spend most of our time this evening, is on premature ejaculation. Retrograde ejaculation over here in orange is a condition where the man experiences the sensations of orgasm or ejaculation, but he ejaculates backward into the bladder rather than out the front of his penis. So this is a definition of premature ejaculation. DSM-5 stands for the Diagnostic and Statistical Manual, the 5th edition, and a text revision. So these are the criterion that clinicians diagnose premature ejaculation. It begins with the first one, a persistent or recurrent pattern of ejaculation occurring during partnered sex. That's really important because it's not referring to masturbation. It's not referring to other forms of sexual activity. It's really about vaginal penetration and how long the man is able to stay within the vagina without ejaculating. So it continues to read within approximately 1 minute following vaginal penetration and before the individual wishes it. Now, some men wish to ejaculate quickly, so that's not a dysfunction, it's just their preference. But many men prefer to last longer than a minute. Then the second part of this is this issue of premature ejaculation with vaginal penetration must have been present for at least 6 months and must be experienced in almost all or all, they refer to it as 75% to 100% of occasions of sexual activity. Third, that this causes clinically significant distress, frustration, or upset. And the last point is that the dysfunction is not better accounted for by another substance, a medication, a medical condition, or something relational like a disordered relationship or stressors or other things. It really is on its own. The DSM asks us to specify, and this is important, whether the man has lifelong or acquired PE. Lifelong refers to the man having experienced rapid ejaculation at his very first episode of intercourse and it continuing in that manner throughout his life. Acquired refers to the man had normal ejaculatory function and then somewhere in his adulthood developed premature ejaculation. And the last point is we look at whether it occurs with all sexual partners, and we call that generalized, or situational. It only occurs with one sexual partner or one type of position or something that's situational, but not all. So people keep asking, well, what's the normal ejaculatory function? How long should men be in the vagina until they ejaculate? Now, the word here that to look at is the median. And IELT stands for intravaginal ejaculatory latency time, or the time from penetration to ejaculation. The median time, which is a way of doing statistics, is 5.4 minutes. The mean, however, that is the average, would be a bit longer, between 6 to 8 minutes. But that gives you a sense of between 5 minutes and 8 minutes is generally considered, quote, normal, unquote. And it varied in studies that were done between countries. It was independent of the use of condoms or even circumcision status. Many people thought, well, if I wear a condom, it'll really slow me down. That's generally not true. And men go on as adults to get circumcised because they believe it will make them less stimulated. And again, that's not true. And so this study has been repeated several times over the years, and the results remain the same. So I want to call your attention to the first two rows here that say lifelong or acquired. Now, Jeff, in his introduction, said this is the most frequently diagnosed sexual dysfunction. The truth is that it isn't the most frequently diagnosed sexual dysfunction. Many men in surveys will say, well, I have premature ejaculation, but they don't qualify based on the DSM-5 standards. So these are two studies, one done in Turkey and the other done in China. And you can see that only 2.3% of men in Turkey or 3.2% of men in China had the lifelong form of premature ejaculation, and 3.9% in Turkey and 4.8% in China had the acquired form. Remember, all his life, since the very first time he started making love and having intercourse, versus a period of normal functioning and then developing acquired. I'm not going to speak tonight to these two, variable and subjective, because they're really provisional diagnoses and most of us don't use it. So these are coming from the guidelines that we wrote on the etiology or the cause of premature ejaculation. You can see there's a long list here. Hypersensitivity of the glans penis, higher cortical representation of the pudendal nerve, disturbances in central serotonergic neurotransmission, erectile difficulties, prostatitis, chronic pelvic pain, a varicocele or thyroid disorders. Now, yes, some men, these cause PE, but please look at the last two notes. It's noteworthy that none, I'll emphasize none, of these organic etiologies has yet to be supported by robust and large-scale studies. And to date, no biological factor, I'll repeat that, no biological factor has been shown to be causative in the majority of men with PE. So the fact is, I hate to say this, the answer is we really don't know what causes premature ejaculation medically. And I'll show you some of our thoughts psychologically in a second. But here we are, it's a bit of a quagmire because we don't know. Here are some of the psychological theories. Relational or interpersonal conflict. It's a conditioned pattern that is actually Masters and Johnson many years ago, I think in the 70s, said, well, the majority of men had sex in the back seat of a car and tended to hurry up, and they conditioned themselves to ejaculating quickly. Most of us tend not to believe it, but it's certainly an interesting one. There are people that write that ejaculating quickly is a way of being hostile to women in that they can't enjoy the sexual experience because it's over with so quickly. A very Freudian idea would be fear of the vagina. And over the years, once a year, I get a guy that comes in, he jokes with me and he says, I'm really a Freudian case. I really am frightened of putting my penis in the vagina. And he thinks that caused him to ejaculate quickly. However, this is the important part of this slide. Performance anxiety. The worry that this will happen again and again and again maintains the dysfunction. Now, what's the impact on the man and his partner? So it's associated in research we did with diminished sexual satisfaction for the patient and partner. It negatively impacts on self-esteem, sexual confidence, and intimacy. And men are very bothered by this dysfunction. The partners of men with PE are likely bothered. They don't understand why, if they've had other partners that have lasted longer, he has PE. And because they tend not to talk about it, it's a kind of a cone of silence. It's damaging to the relationships. And this last point is really important. That PE interferes with single men beginning new relationships because they're afraid that people will find out about this, they'll be humiliated, and the woman will break up with him again. It's really having premature ejaculation is a strain on the relationship. It tends to lead to distrust and the loss of hope that this will ever get better. Women, when it's a heterosexual relationship, perceive the selfishness of the man. And men, as I said, have difficulty initiating and maintaining new relationships. And couples have difficulty talking about this. The partner often doesn't want to raise the issue. She doesn't want to hurt the man's feelings. She's not even sure how to discuss this. And some partners may think it's a normal situation. And many think there's no solution. So just to give you 2 slides here, that these studies were done on women whose partners had premature ejaculation. And their major upset, these women reported, that is 47% of them reported distress, had to do with that he was so focused on not ejaculating quickly. It's like he's in another zone. He's not relating to her. And then, of course, some of them, 39%, were upset because there was rapid ejaculation. These are, on the left of this slide, are pictures of William Masters and Virginia Johnson. On the right is a fellow by the name of James Siemens. Masters and Johnson advocated for a squeeze technique. That is, they advocated for women squeezing underneath the head of the penis, where they call the frenulum. And they thought that would decrease his stimulation. And often they suggested the man withdraw from intercourse or the vagina, and hopefully that would help him last longer. I tend not to use that technique because I don't think it works that well. Siemens suggested something that I'll talk more about in a minute, which is the stop-start technique. Where there's the beginning with masturbation, going on to manual or oral stimulation, and then resolving with intercourse. So he had a more graduated behavioral approach to this that works fairly well. So these are things that we do in terms of psychologically or behaviorally. I mentioned the squeeze technique by Masters and Johnson. And then we have sensate focus, which is a way of having the man focus on being touched and touching the partner. Stop start, which is Siemens' idea. Quiet vagina, which is just inserting the penis in the vagina and laying there and getting used to the wet and warm sensations. There's no thrusting because we don't want the man getting overly stimulated. We use cognitive behavioral approaches. Some people add on pelvic floor exercises, and an integrated approach would mean using some form of medication with these. So cognitive restructuring. Men have all these negative thoughts. I'm a complete failure because I come too quickly. I can't control it last time, so I won't this time. My partner says it's okay, but she doesn't want to hurt my feelings, and you can read the rest of the list. All of these things go through the man's mind, but distract him from being present. He's so worried about ejaculating quickly that he can't be in the here and now and focus on what it's like to be with his partner. Now, in terms of doing psychotherapy, which I tend to do, it's clear that the results are not immediate. And what's really clear is there's a benefit to rapidly demonstrating efficacy to patients. And we do that by sometimes combining the psychotherapy with one of the drugs that I'll talk about in a minute. However, therapy for those that don't have insurance can be costly and time-consuming, and we don't have an abundance of well-trained, experienced sex therapists. However, these days, we're allowed to do work online and see patients in different states. So these are the drugs that have been written about that delay ejaculation. The first is a drug called clomipramine or anafranil. You've probably heard of fluoxetine or Prozac, sertraline or Zoloft, paroxetine or Paxil. Prozac, Zoloft, and Paxil are SSRIs, meaning selective serotonin reuptake inhibitors. They're used to treat depression and anxiety. Prilocaine lidocaine cream is a just cream that's put on the penis. I'll show you a study with that in a minute. And there's another drug called tramadol, which we don't use very much because it's a narcotic. So this is a study of men who used a drug that's in the United Kingdom called Fortisyn, and they have a drug here called Promescent. So Promescent is a spray. You spray it on the penis, and it has a chemical structure where instead of staying on the penis, the drug is absorbed into the skin of the penis, so there's little to no transfer to the partner. We don't want the partner's vagina going numb after they use this. And if you look at this, these two groups, the first is a placebo group here in dark blue. In purple is the group that got the drug at baseline. Then this is 3 months later. There's a very small improvement in the placebo group, but a significant improvement here in the group that used the spray. So it was a 6.3-fold increase. So if the man lasted 1 minute, he can now last 6 minutes. And with placebo, it was a slight improvement to 1.7 minutes. So again, this isn't a bad start. You know, the side effects are very minimal with this. Transfer, if you use Promescent or Fortisyn in the UK, is very minimized, and it tends to work fairly well. So let me sum up here that I think PE is a vexing and distressing problem for both the man and his partner. On its own, the dysfunction is not likely to get better, and there are several options available to men and their partners, which include combining the drug or the spray and some form of behavioral or psychotherapy. And that's really the best way. You're harnessing the power of the mind and the power of the medical intervention to help the man get better. So I'm going to stop here and then take your questions.
Awesome. Awesome. Thank you so much. That was great. And I think it's so important because, as I was saying in my intro, I think the complaint in younger men of this premature ejaculation and maybe not even having a complete understanding of the disparity between how long females and males take to climax, that most males have to alter their climax to match a partner, a female partner in particular, but probably partners anyway, right?
Right.
So it's just a common complaint amongst young men, whereas often erectile dysfunction is more amongst the older men. But it's interesting, and I see as men get older, they're coming in complaining of erectile dysfunction and premature ejaculation, which is a bit of a conundrum because many of the things we do to delay climax can adversely affect erection function. So,
Right.
so it
See,
can
I
be
tend, Jeff,
challenging.
to look at this like, the man knows he's going to lose his erection. So in
Mm-hmm.
his mind, he's saying, well, I better hurry up and
Yes. Yeah.
ejaculate quickly. It's like the 2-minute offense in football. You want to hurry this up, move faster. But what it does is it conditions him to ejaculate quickly, and it doesn't necessarily fix the erectile dysfunction,
Mm-hmm.
which,
Yes.
as you say, is really an age-related problem, or by and large more of a blood flow related problem. And so, drugs like are what we call the PDE5, the phosphodiesterase inhibitor 5 drugs, like Viagra, Cialis, Stendra, Levitra, are pretty good for maintaining erection. But if the guy focuses in on, I'm losing my erection, I'm going to come quickly, it's a mess. So
Yeah.
he's not focused in on pleasure, his satisfaction, or the satisfaction of his partner.
Yes, and so it produces, and it like you said, it is a mess because the anxiety produces adrenaline. Adrenaline is part of fight or flight. The erection gets worse. They go too quickly, and But what you said, I think, is so important. That being present, and then now they're absent for it. So, and like you, I really haven't found much success with the squeeze technique. I don't really recommend that, but I do use the stop-start technique quite a bit along with other things that they're doing and have had some pretty good success with that as well, just like you said. So I think the really good news for men is that there are treatments, and I think the multimodal treatments, like you said, where you combine some of the behavioral things along with the medications. I have had pretty good success using the
Right.
promescent spray, or and then like you said, even using the SSRIs and different things along with. But you have to deal with the rest. You can't just. I find that the prescription, whatever you give them, or the promescent, is so much more successful when we pull this apart a little and have them really work on things. Do you find that
Right.
in your practice as well?
Yeah, I think the whole idea, Jeff, is to help men develop confidence. There
Yes.
are, again, that they feel devastated having this problem, and the partner's not happy either. So, sensate focus, which
Mm.
is a way where we start off with the man masturbating. And what I tell them to do is imagine a 0 to 10 sort of scale and start, stimulating themselves till they get to about a 6 and then stop, which is something they're not used to doing.
Mm-hmm.
Stop. Let the, stimulation go down to about a 3, start over again. And so what I'm trying to do is get them to attend to how aroused they are. Most men don't want to focus on arousal because if they do, they fear I'll ejaculate. My goal is to get them to know exactly where they are, because that way they can control the where they are. This whole thing is about control. And
Yeah.
once they learn or are able to master the issue of masturbating with the sense of control, and getting confidence, I move them on to doing this with a partner. either through manual or oral stimulation. Again, going to a 6, stopping, starting again, stopping again. But the idea of being present and knowing where they are on that continuum, which many men are just don't want to know where they are, you know? They just
Mhm,
say, it's the
mhm.
mantra, I don't want to come, I don't want to come, right?
Right.
And then moving on to intercourse, but not thrusting, getting used to the wetness and warmth, the sensations, and not ejaculating. And then slowly introducing some thrusting. But it's
Yes.
sort of a behavioral, developing confidence, realizing they're able to do this. And, it works fairly well.
Absolutely. I think that it is a cognitive restructuring. It's a restructuring of their thinking. Absolutely.
Right.
But it's also, like you said, we have them start working together. Okay. Can have the penis and the vagina. Nobody moves. Get used to it. You're in there. It feels good. Nothing's happening. You got this. Once you've built that level, now moving to the next. I think it's so important for the couple to work together on that. Exactly as you said, getting used to some simple thrusting and all those different things. I use those exact things
Right.
along with it
Right.
too.
Yeah.
So I think it's great. We got a couple questions for you, so I'm going to feed you those. This is from Peter. He says, "Hi there. I'm on a flight and lost video, so forgive me if this was asked or covered already. I tend to offer medications first for this, Paxil, and then concurrent psychotherapy. Is that an acceptable plan of care?"
So the Paxil, what you're really dealing with the Paxil and other SSRIs, you're banking on the side effects. And yes, it will, but they're not gaining confidence.
Mhm.
They need to feel like this is me, I'm doing something. And so therefore, I think that the Paxil or whatever drug you choose needs to be combined with something that the
Mhm.
man is doing, so he has a sense of, this is me as well as the drug.
Yes.
So I think that's, it's not start with A, start with B. I would start with both. And I take we have a discussion about why. I want them to know why we're doing this, because I want them to be able to focus on what they're doing and get out of the negative cognitions that they've been thinking about for years.
Mhm.
And they have to have that ownership of it, that self efficacy, that they will do better.
I think you're absolutely right. I find, Peter, I find that I use those somewhat as a little bit more of a last resort, but I will put it in there earlier. And honestly, what I do is like you do, Dr. Althof, I talk to the patient and see what their goals are. I work with them on what they're comfortable with. And I find a lot of patients are resistant to having to take a medication, for especially a medication for depression or anxiety if they
Right,
don't have
right.
to take it. So, and we do find initiating the behavioral techniques can be just as successful if you work with the patient on building confidence. You work on these behavioral things. And I think a combination of behavioral medications can be good. So there's no absolute right or wrong. Do this, don't do that. But I tend to leave them as a more of a last resort. I try first other things. But if the patient comes in and says, I've heard these SSRIs are going to really help me, I really want to try that, it's always patient centered, then I'll go with
Right.
that. But I agree with you. I think working with them on this, using some behavioral things, and I always like the couple to come in together. If the partner will come in, I like to work with them together so they can work together on this. And so often my patients are very comfortable bringing their partner or partners in so we can work together on all the different aspects of it.
Yeah. I get concerned because the SSRIs do have side effects.
Yes.
And, we need to, of course, tell the patient, disclose to them what potential side effects there might be. And as you said, many people don't want to take a psychiatric medication. You know, uh, because it's not, it's off. We need to say very clearly that the use of any of these SSRIs is off label.
Yes.
And so patients aren't eager to do that. And that's why I often will start with the spray, which has fewer side effects, less transfer, and may begin the person to have some success. They then may want more, and then we can talk about the medications. But the medications are not sort of free of charge. They have the side effects. They're troubling. And, we don't like to make people feel worse.
Definitely. And also, while we're talking about that, just so everybody knows, when you look at the research, they studied these medications, taking them 3 different ways. You take it regularly, just like you would for depression and anxiety. And that's the way they found it can work the best for premature ejaculation.
Right,
Again,
right.
off-label, non-FDA approved. Some studies showed if you take it for 30 days straight and then on demand several hours before, that can be a way, and that worked. That had efficacy and safety as well. And then finally, just on demand, not any 30-day or any daily use. But like you said, patients are going to complain about things. And one of the number one things they complain about is it may make them sleepy or tired.
Right.
It may affect restfulness. It may upset their stomach. It
Yes,
has its
right.
price to pay.
Yeah, right.
And you
Right.
are 100% right with that. I have another question for you. I thought it was a good one as well. Have you tried injections of erection agents which cause a 1-hour erection? Is this helpful? And I would say, because I know you don't prescribe those things, Dr. Althof, but I do, we do not typically use that erectile dysfunction agent for premature ejaculation. It is not typically thought of as a treatment for that. But now, if a patient was interested in that and they had difficulty with erections, which can also come hand in
Right,
hand with
right.
premature ejaculation, it may be something that is used to treat the erectile dysfunction. And certainly it could help with the premature ejaculation, because you won't necessarily lose that erection when you climax on a vasoactive drug that is injected directly in the penis. But again, here's the thing. Now you're asking the patient to inject something into their penis rather than just take a pill, and there are side effects and many things to think about. So again, it's always patient-centered. What do they want? What are they comfortable with? I tend to go with, when they ask me, I say, let's start with least invasive things, behavioral things, the spray, different things like that, and then move to some of the other things. But if they want to do different things, it is patient-centered.
Right. I tend not to recommend the intracavernosal injection. We did a lot of research on intracavernosal injection for, erectile dysfunction. But
Mm-hmm.
I don't think that's necessarily the best treatment. I know there are clinics out there, they'll sell you the drugs, but that's not how we want to go. We
No.
want to, as you say, be patient-centered or focused on what the patient wants. And I think there are less invasive, easier, and more successful treatments, which include the, I call them the PD5 pills, Viagra, Levitra, Cialis, Stendra,
Mm-hmm.
that have been incredibly successful in restoring erection.
Mm-hmm.
And the intracavernosal injection is, I think, the next line above that. If those pills
Yes.
don't work, consider it. But that's not where I would start.
Yeah, agreed. And then there's the vacuum pump and other things to think about
Right,
with erectile
exactly.
dysfunction. I have 2 more good questions for you. Here's another one. Can relationship dynamics play a role in PE? And if so, how?
Well, in many different ways. So I'll give you this short case example. I saw a man, he was a law enforcement officer. He came in to see me, and he was dating a CEO of a company. And he said, I started to develop PE. And I said, that's unusual. What happened? And I asked if he had ever had the same thing, had PE before. And he sort of laughed and he said, about 15 years ago, I dated somebody who was in a high-level position like the CEO. And, he was smiling and it all came together for him. He recognized there was something in the power dynamics that was going on that was troubling for him. And, and that he recognized it himself. I didn't have to do much. And he realized this, I probably don't do as well with somebody who's in this high level power position, that I'm not. And I thought that he got it very quickly. So yeah, relationship dynamics really play a role. It's a way of dealing with the relationship itself. If the relationship isn't terribly satisfying, you wonder then if the man hadn't had premature ejaculation, the lifelong problem, why it developed when it did. And you become a bit of a detective. What was going on in your life then? Why then? Oh, my wife started to do this, or, my boyfriend started to do that. So you really become an archaeologist, a detective, and you explore what's going on in the couple's life at that point. And that often leads you to some very interesting stories.
I think that's absolutely true. And so often what we're doing with our history and physical and all that is trying to peel back the onion to really see how did this start? Where did it come from? And that's why it's so important, like you said, to differentiate lifelong versus, because that's really important, because now we can kind of see, when did it start? How did it start? What are the dynamics? But it is amazing how when you pull it apart, even he pulled it apart and was like, had an aha moment. Wow, I get what's going on here. Another good question. How can couples communicate openly and supportively about PE without creating additional pressure?
So couples know there's a sexual dysfunction. Absolutely. It's not like a news flash. It's not like a secret. It's not hidden. So the question is for couples to talk about this outside of the bedroom, like to recognize that, you seem to ejaculate more quickly than other people I've been with, or the man says, I know this is a problem. I've had it with partner 1, 2, 3, and 4. I don't know what to do. And so empathy goes a long way. It must be difficult for both of them. Mm-hmm. And what you try to say is, how can we make this better for you as a couple? And it's not just the ejaculation, but how can we make the sexual experience better for the partner and the patient, and in the process, lengthen the ejaculatory process as well. So, it's really trying to get them to talk to each other openly, honestly, not in a demeaning or angry way, but to recognize we have an issue, we have a problem here, and we want to do better. I want to be able to have you say you're satisfied with your sexual life, and it'll make me feel better about a lover if I could do it as well. So there's a sense of gaining confidence and knowing where things are a little off track. But not talking about it, I think, makes things worse.
Yes. I think you bring up one really great point you bring up is during the sexual act is not the time to talk about it.
Right.
But outside of the bedroom in a loving way to bring it up without shame or blame, basically just saying, I'm feeling this when this is occurring. And I think we could work on things. We have this wonderful love life together. I think we could make it better if we work on a few things. So I think that open communication is really, really helpful.
I think so too, because I think, she may say, gee, I'm not having orgasm. And then you could discuss the idea of, well, do you want to, have an orgasm first? And then we can go on to intercourse. Mm-hmm. And, there are all sorts of ways for, a heterosexual couple for her to have an orgasm, whether it's by vibrator, hand, mouth, whatever. Mm-hmm. But then it may be more satisfying. And the PE may not be so difficult then. So the idea is to know, I want you to have a good sexual experience. And if we just stay intercourse focused, we're going to get ourselves in trouble.
And like you said, that woman may be multi-orgasmic. So once she starts orgasming, she can have continued pleasure throughout. So the foreplay becomes really an important thing to focus on. And whether that was a female or male, matching up climaxes, no matter whether you're a man with a man or a woman with a woman or a woman with a man, it can be challenging, you know?
Yeah, sure it can. And the idea is you don't want to get in your mind everybody has to ejaculate or have an orgasm every time with, I mean, otherwise there's
No.
enormous pressure again.
Yes.
And this should be fun, erotic, exciting, but not necessarily pressure filled and goal oriented sex. You have to have 2.5 orgasms. I have to last 9 minutes. I mean, you get yourself into these situations that are not helpful.
Totally. And it is supposed to be fun. That's the whole
Right.
point of it. And two, I always say, let's make sure pleasure is at the top of the list of our goals here. And like you said, sometimes it can be fun. Maybe you didn't have a climax this time. It's like, okay, well, let's try this again tomorrow night and focus a little bit more on me. That'll be fun too. So I think all of that can work, and it doesn't always have to be reciprocal in every single circumstance, and it doesn't have to be perfectly aligned either. I mean, it can be a wonderful thing to experience your partner's climax on their
Right.
own. So I think
Right.
all that's true. I think all the expectations we put into it are a big part of the problem. And I think you've done a great job unpacking this for us this evening. I really, really, truly appreciate it so much.
You're welcome.
So, before I go into the closer, I would just like to see if you have anything else you'd like to add, Dr. Althof. And then what we do is we kind of do a centering closing exercise, and then we'll talk about what's coming up next week and close out the show. Is there anything else you'd like to share before I go to the closing exercise?
Well, I just want to give people hope that people get so discouraged and it becomes so problematic that they have to recognize there are things that we can do. Some of it is not that complicated, but they have to be willing to talk about it, be present, and engage in some of the therapies that we suggest to them. So I have a lot of hope for this, and that I know that by itself, the dysfunction is not going to get better. But with whether it's a behavioral intervention, a medical intervention, there are things, Jeff, that we can do.
Absolutely. And so, yes, I think hope is amazingly valuable, and there is so much hope when it comes to these sexual issues. And if you're looking specifically for a sex therapist or counselor, I'm a counselor and Dr. Althof is a sex therapist as well. You can go to AASECT, the American Association of Sexuality Educators, Counselors, and Therapists.org. Hit the find a provider button, and you can find people in each state and look for someone near you. And these days, like you brought up with telehealth, you don't have to find somebody in your state. Even sometimes it is possible at times to see people on telehealth as well. So you can find a great provider to help you with that hope. So having said all that, when we finish out our each of these episodes, we like to get you centered because it was a lot of information coming at you. Awesome, great information. So let's take a moment to pause and settle into a comfortable position. If you're able, gently close your eyes. Now take a slow, deep breath in for several counts. Feeling the air expand in your chest and your belly. And as you exhale fully, release any tension you may be holding. Feel any tension within your body and work to let go and release it. As you breathe in for 4 or 5 counts, and you exhale for 4 or 5 counts, as you exhale, release that tension. Let your shoulders drop. Let your jaw, where we love to hold tension, let your jaw soften. Relax the muscles in your neck. Release the tension in your pelvic floor area. With each breath, allow yourself to let go of any lingering thoughts, self-judgment, or expectations. Now bring to mind, as you keep breathing in 4 counts, and exhaling 4 counts. Bring to mind this simple intention. I am patient with myself and my journey. I embrace pleasure without pressure. I trust my body and allow myself to be fully present. We learned how important all of that is with issues like premature ejaculation. Take another slow, deep breath in and exhale completely. When you're ready, gently open your eyes and carry these intentions with you. I thank you so much for joining us this evening, and I thank our special guest, Dr. Stanley Althof, the expert on premature ejaculation. And let's find out, Vic, can you tell us what's coming up next week on Dr. Jeff Talks About Sex and Intimacy?
Religious teachings shape our view of sexuality, dictating when and how it should be expressed. Purity culture in some religions links sexuality to shame and guilt, overshadowing authenticity and freedom. It's about obligation, not safety. In this episode, Tova Means joins Dr. Jeff to discuss purity culture's impact on sexual development, relationships, and expression. Join us as we discuss how to reclaim a sense of sexual self rooted in confidence, self-awareness, and joy. Coming to drjeffsextalk.com on April 8th at 7 p.m.
So, super excited about that topic. And that was a topic that you, our listeners, actually asked for. And I found someone to speak on that. And it's going to be a really good episode next time. So thank you for that suggestion, Lori. It was an excellent one. And we're really excited about that next week. Thank you for participating, all of you for watching, and thank you so much, Dr. Althof, for sharing your amazing expertise. I've learned so much from you over the years and continue to learn from you. So thank you for sharing with our listeners.
Happy to.
Have a wonderful evening, everybody.
Take care. Good night.